Good afternoon, everyone. My name is Dr. Diane Barish, and it is my pleasure today to serve as the host for this CGNE Seminar Series session. This program is being provided by the Tresenice and Helen Diskovich Center for Geriatric Nursing Excellence at the Penn State Ross and Carol Nease College of Nursing in collaboration with the Outreach and Professional Development Office, the Center for Nursing Research, and Age-Friendly Care PA. So today's seminar is titled Cognitive Decline and Dementia Risk in Older Adults, and it will be presented by Dr. Christopher Engeland, Associate Professor of Biobehavioral Health from the Penn State College of Health and Human Development. Easy for me to say. Before the information session begins, there are some disclosures and announcements that we have to go through here. The Penn State Ross and Carol Nease College of Nursing is approved with distinction as a provider of nursing continuing professional development by the Pennsylvania State Nurses Association, an accredited approver by the American Nurses Credentialing Centers Commission and Accreditation. Participants with a valid RN license who attend the entire nursing continuing professional development program can earn 1 contact hour. Partial contact hours are not awarded. The topic of this education is non-clinical, and therefore we did not identify, mitigate, or disclose relevant financial relationships. In order to earn your contact hours, Zoom in and out times are recorded, and the post-event evaluation survey must be completed. So our seminar is being recorded today. Any questions that you have that you want to ask Dr. Engeland, please put those either into the Q&A or chat features, or you can also raise your hand and we will unmute you when we get to the discussion portion of the seminar. The post-event evaluation survey link will be placed into the chat after we have our presentation, and it will also be emailed to you within 24 hours. The evaluation must be completed within 1 week of the seminar in order to obtain your contact hours if you have an RN license that you're seeking contact hours for. We also ask that all attendees complete the post-evaluation event. We also ask that all attendees complete the post-evaluation survey to help out with the Age-Friendly Care PA and our data collection efforts, even if you are not an RN. And the Center for Continuing Professional Development certificates will be emailed to registered nurse participants meeting all requirements within 1 month following the seminar. So next, I would like to introduce to you Yo-Jen Lau. She's a CGNE graduate student affiliate. She is currently enrolled in our PhD program with a focus on pain assessment in older adults living with dementia in long-term care. So thank you for introducing the speaker today, Yo-Jen. Over to you.
Thank you, Dr. Barish. Dr. Christopher Engeland is an associate professor of biobehavioral health and joint faculty member at Ross and Carol Nease College of Nursing at Penn State University. He earned his PhD in neuroscience at the University of Western Ontario in 2002. Dr. Engeland's research interests include the effects of stress, age, sex, and hormones on health outcomes such as inflammation and wound healing, preterm birth, depression, cognitive aging and decline, and dementia risk. His recent focus has a strong emphasis on the pathophysiology and early detection of Alzheimer's disease. He has 80 publications, multiple NIH-funded grants, and is the incoming president of the Psychoneuroimmunology Research Society. Welcome, Dr. Chris Engeland.
Thanks. I'm going to share my screen. Can everybody see that all right?
Looks good.
Okay, wonderful. So I'd like to thank the CGNE and in particular Janice Whitaker for the opportunity to speak with everybody today. On this slide, you'll see pictures of 8 different individuals who have passed away from dementia or with dementia. So we see starting off in the top left, Rita Hayworth, Jimmy Stewart, Ronald Reagan, Peter Falk. A lot of these people are actors. Gene Wilder, Charlton Heston, also a famous hockey player, Gordie Howe, and Robin Williams, another actor. And of course, you'll note that a lot of these individuals, some of these individuals perhaps you don't even know, tend to be older because Alzheimer's disease and dementia are diseases of aging. And part of the problem that we have these days, just trying to advance my slides here. And there we go. Part of the reason that Alzheimer's has become such a large health concern is because we have an aging population. So for objectives for today, I wanted to describe the problem of Alzheimer's disease a little bit further. I'm then going to talk about the pathophysiological changes that occur in the brain as an overview. I'll talk about current treatments for Alzheimer's disease. One just came out 6 days ago. I'm going to talk about treatments that are currently in development, the importance of early detection of dementia and Alzheimer's disease. And then I'll talk a little bit about blood-based biomarkers and cognitive testing and how they may be able to provide us some information in trying to promote early detection. And then I'll talk about the path forward and what sort of hope remains for combating Alzheimer's. So presently in the US, over 6 million Americans have Alzheimer's disease. This is about 1 in 9 people over the age of 65 and 1 in 3 people over the age of 85. 96% of cases present themselves symptomatically after the age of 65, so 65 onwards. 4% of cases present themselves symptomatically before the age of 65, and this is also Alzheimer's disease, but is considered to be early onset Alzheimer's. And if you hear about Alzheimer's having a strong genetic component, it's this early onset Alzheimer's that people are typically referring to. So this is where cases are going, and the number of new dementia cases is projected to more than double by 2060 from where it is now. So right now we're a bit over 6 million cases, and it's projected to go up to 13.8 million cases just in the US by 2060. And healthcare costs, which based on 2021 parameters were 321 billion, are estimated to go up to $1 trillion or higher by 2050. So this is going to be a huge, huge economic burden for any country that has an aging population. The United States, Canada, countries in Europe, Japan being prime examples. Not only do we have incidence of Alzheimer's increasing so much to an aging population, but we haven't unfortunately made a lot of progress with its treatment and stuff, as I'm going to discuss further. This is the change in selected causes of death between 2000 and 2019, and you'll see that breast cancers increased by 1.1% in that 20-year period, prostate cancer 1.8% increase. We had a 7.3% decrease in heart disease, and a little bit over a 10% decrease in stroke, and a 65% decrease in HIV deaths in that 20-year period. And if we contrast that to where we are with Alzheimer's disease deaths have increased by 145% in that time. So just to sort of make sure everybody's on the same page, I'd like to go over the stages and signs of Alzheimer's quickly. Very first early indicator, and this is not Alzheimer's at this point, but it's mild cognitive impairment. So this is when people display more memory problems than what's typical for their age. It's not as severe as Alzheimer's disease. It does not significantly impair daily activity, but anybody with Alzheimer's disease will go through this stage of mild cognitive impairment. Not everybody with mild cognitive impairment will develop Alzheimer's disease. But again, this is a stage that everyone with Alzheimer's will go through. I should mention that Alzheimer's comprises 60 to 80% of dementia cases. So it's the most common form of dementia there is. The first stage of Alzheimer's is divided into 3 stages. It's mild Alzheimer's, and this is where we see memory loss and other cognitive abilities worsening. People might get lost, repeat questions, certain tasks take longer than usual. They may have trouble with numbers and money and paying bills, and diagnosis generally occurs in this stage. As the disease worsens, we get into the stage of mild Alzheimer's disease, and brain centers at this point that control language, sensory processing, and conscious thought undergo significant damage. Memory loss and confusion worsens. At this point, people may have trouble recognizing people they know. They become unable to carry out complex tasks, unable to learn new things, and delusions and paranoia are not uncommon. And moving into the final stages of Alzheimer's, people spend 40% of their time here from the point that they are diagnosed with Alzheimer's disease. There's extensive damage to the brain at this point. The brain shrinks due to cell death. You can see that in the diagram at the bottom. And people eventually become unable to communicate, to respond to their environment. They ultimately have complete dependence on others. Their muscles grow rigid, swallowing becomes impaired. And a lot of people with Alzheimer's disease will pass away from things like pneumonia due to having trouble swallowing and getting liquid in their lungs and infection. They may pass away from things like heart attack or eventually slip into a coma. And I should mention that Alzheimer's is the number 6 leading cause of death. So this disease was first described by a German pathologist, Alois Alzheimer. In 1901, he began studying a 51-year-old woman who had memory loss, language problems, and unpredictable behavior. And this was unusual for somebody who was this young. This was actually a case of early onset Alzheimer's disease. And he termed the condition pre-senile dementia. If this individual had been in her 70s and was showing the same symptoms, back then they would have just looked at this as being typical older aging and senility. After she died in 1906, Alois Alzheimer found many abnormal clumps, which are now called amyloid plaques, and tangled bundles of fibers, now called neurofibrillary tangles, upon autopsy of the brain. And these are the two discriminating pathological items in the brain that have to occur for us to consider something to be Alzheimer's disease. The people have amyloid plaques and that they have neurofibrillary tangles. So these beta amyloid plaques, they form with an insoluble form of amyloid in the brain that we really can't clear. And they form outside of cells and they cause damage by impairing glucose metabolism in the brain, interfering with calcium regulation, increasing destructive free radicals. They cause immune cells like microglia to aggregate and to try to destroy these clumps, which causes neuroinflammation, and they prevent cell-to-cell signaling. So there's a lot of disruption that occurs from these plaques, and in conjunction with these plaques, we also get a hyperphosphorylated form of a protein called tau. And tau is very important in neurons for maintaining microtubules. And what happens when this protein becomes hyperphosphorylated is that these microtubules break down. And they're important for the cytoskeletal structure of the cell. So ultimately, our neurons start to deteriorate and die. And it's these two things in combination that ultimately form Alzheimer's disease. So again, amyloid plaques and neurofibrillary tangles, resulting in cell death and brain atrophy. And we can see here, here's a healthy brain, here's a mild Alzheimer's disease and severe Alzheimer's disease. I can see this in both cartoon and in PET scan. And there is a great reduction as the disease progresses in brain tissue, which of course relates to the symptoms and loss of functionality. So the amyloid cascade hypothesis is basically the idea that it's this accumulation and deposition of amyloid in the brain that initiates the event of irreversible progression that culminates in Alzheimer's disease. So the idea that amyloid depositions are driving the disease. And if we look genetically at what the risk factors are for Alzheimer's disease, that would seem to support this idea. So in early onset Alzheimer's, people who develop it before the age of 65, there are 3 different genes, APP, PSEN1, and PSEN2. And if a person has a certain mutation of either one of these 3 genes, they will develop Alzheimer's disease, and it's associated with an increase or an overproduction of amyloid. If we look at genetic risk factors in late onset Alzheimer's disease, which is the Alzheimer's that most people will develop if they do develop it, there's a gene that you've probably heard of called ApoE. It comes in different forms, ApoE2, 3, and 4. And if people have the ApoE4 allele, this is associated with reduced clearance of amyloid. So the genetic risk factors have to do with overproduction of amyloid and or reduced clearance of amyloid from the brain. Well, to sum up then, the major pathological changes again in the brain are these amyloid plaques, neurofibrillary tangles, we get neuronal loss and ultimately cerebral atrophy because of this. So I mention all of this because this, of course, informs treatment and what we're able to potentially do. So the current treatments for up until very, very recently, treatments for Alzheimer's disease focused largely on the symptoms of memory loss. So the treatments were attempting to lessen or stabilize these cognitive symptoms. And importantly, understand that when people are being treated in this fashion, that these treatments are not going to stop the damage of Alzheimer's disease. They're not even going to slow it down necessarily, but they're going to allow the brain to work for a short period of time, perhaps in a bit of a better fashion, so that some cognitive ability is maintained. So the main treatment that's occurred over the years has been cholinesterase inhibitors. There is a neurotransmitter in the brain called acetylcholine, and this is the neurotransmitter that's affected most in Alzheimer's disease. So people with Alzheimer's have very low acetylcholine levels. And what a cholinesterase inhibitor does is it inhibits an enzyme that breaks down acetylcholine. So ultimately, these drugs then allow for more acetylcholine to be available in the brain. So here we have various different cholinesterase inhibitors that have been approved for use over the years. And until very recently, this was really the only medication that was available for Alzheimer's patients in the early stages. And this is typically administered to people in the early to moderate stages of Alzheimer's disease. There is another drug called memantine that reduces neurotoxicity later in the disease. It's given in moderate to late stages of the disease. I mention it because it is out there. And again, until very recently, these were the only drugs available for Alzheimer's. Until 2021. So aducanumab, also called Aduhelm, is composed of human monoclonal antibodies. And what they do is these antibodies bind to amyloid beta. So this amyloid that I'm talking about forms these amyloid plaques. And what it does then in binding to amyloid is that they promote its removal by phagocytosis by microglia. So they're basically signaling the immune system within our brain to destroy this material, these amyloid plaques. This was controversial. There was an advisory panel of the FDA that voted to reject approval of this drug in December 2020, with experts on the panel saying that the drug failed to demonstrate efficacy and that more research was needed. Despite this, in June 2021, aducanumab received accelerated approval by the FDA for treatment of Alzheimer's disease. And I want you to understand that there have not been a lot of drugs again for Alzheimer's, right? People are in a sense, we're getting a little bit desperate to, have something approved. I'll get into that a little bit more towards the end of this. So the previous drug that was approved by the FDA for Alzheimer's was approved in 2003 and advanced to 2021. So this drug gets approved in a controversial manner. And it was controversial because it was approved against the recommendation of the FDA's own advisory panel. Clinical trials that were performed on the drug did not prove that the drug improved cognition. 2 trials were stopped early because no clear clinical benefit was shown, although it did show that amyloid levels were reduced. And this drug was fast-tracked, which also was something that is irregular in FDA procedures. So this has implications for other drugs if drugs sort of going to get pushed through very quickly and not follow all the same sort of milestones that other drugs might have. So the idea with this was, well, if you give a higher dose of this drug, it may have some efficacy, especially in people who have higher risk for Alzheimer's, like ApoE4 carriers. And again, as I mentioned, total amyloid level was seen to be decreased in individuals. And this is importantly, it's the first drug to actually target the underlying etiology of Alzheimer's disease. So here we are trying to actually target amyloid and reduce amyloid in the brain, right, as opposed to trying to treat symptoms. So trials have been focused on mild cognitive impairment and early dementia in individuals with a known accumulation of amyloid plaques. There are a lot of side effects of this drug. This is part of the problem, is its safety profile. So there are headaches, dizziness, nausea, confusion, vision changes, and very, very importantly, brain swells and brain bleeds that can lead to things like stroke. So this underscores the importance of accurate diagnosis. We wouldn't actually want to give this drug to somebody who wasn't going to develop or hadn't developed Alzheimer's disease. A few important points here. Is this drug a cure? It is not. There was a lot of damage already done at this point in people with Alzheimer's disease. And really what it's trying to do is to limit further damage and to limit then further cognitive decline in those individuals. So the idea of this type of drug is a sort of trying to arrest somebody at a state of decline as opposed to restoring things. So importantly, it's not going to restore lost cognitive function, but may prevent the future loss of cognitive function. So this is the hope for this type of a drug. Now this drug cost $56,000 when it came out, and Medicare and Medicaid were not covering this drug. They eventually dropped the drug to $28,200. This is per year for families to try to pay for this. Again, different insurance, Medicare, Medicaid was not covering the drug. And it really wasn't outside of these clinical trials really catching on and selling very well because of this very, very high price point. So this drug is largely being removed, but the same company, Biogen, has just 6 days ago introduced another drug that works basically the same way, and it's called lecanemab or Leqembi, and there is some evidence of potentially higher efficacy with this particular drug. So there was a study done over 18 months with 1,800 people who either had who were in stages of early Alzheimer's disease, and they compared to people who are on placebo to people who are on lecanemab. And what they found was that there was a 27% improvement over that 18 months of on cognition, or maybe better way to say it is the reduction in cognition over that time period was 27% less in people who are on this drug versus placebo. So there is some stronger evidence of efficacy with this drug. The safety profile concerns still remain, and it's unknown what's going to happen insurance-wise with this. So Medicare and Medicaid are trying to decide if they're going to cover this drug or not. Its current price point is $26,500 per year. So this is a very, very new development in how we're treating Alzheimer's, these two drugs. And again, this one just came out 6 days ago. There are other treatments being developed. So these monoclonal antibodies I've talked about, there are other ones being developed. There's a list of them here. Treatment with these antibodies in various clinical trials has not been shown to slow cognitive decline in early onset Alzheimer's disease. But certain biomarkers that relate to tau levels and neuronal damage are shown to be reduced with these treatments. And so these clinical trials now are giving higher doses and longer treatment times, trying to determine if these drugs should be further pursued aside from what's currently been released. I think one of the more interesting things that may come out is this idea of a DNA-based vaccine against amyloid. So this is in animal studies, This has been shown to be pretty safe and effective at preventing amyloid accumulation in the brain and preventing cell death. So clinical trials, I think they just started in December, are starting in individuals with mild cognitive impairment or early Alzheimer's disease, where they receive a vaccine, and that vaccine then instructs our immune system on then how to target amyloid, similar to, a flu vaccine or a COVID vaccine. Some of the other approaches that are being pursued are anti-inflammatory drugs, because we get a lot of inflammation in the brain when there's damage like this. And a number of other molecules are being pursued, some that target malfunctioning proteins, some that have been shown to remove amyloid beta clumps from between cells, some that have been shown to reduce the buildup of tau tangles. So these are all being currently funded and researched through NIH funding. And there are some other drugs that have already been developed that are being repurposed for Alzheimer's potentially. So thalidomide, for instance, it's been shown may reduce brain inflammation in Alzheimer's disease. Bumetanide, which is diuretic, it may reduce the risk of Alzheimer's, and Ritalin may reduce the symptom of apathy that's often seen in Alzheimer's patients. So these things are being pursued as well. Gene therapy is being looked at to increase levels of brain-derived neurotrophic factor. And this is a really interesting molecule. So brain-derived neurotrophic factor is this molecule in the brain that promotes neurogenesis, so promotes the formation of new neurons, and it promotes neuronal health, and it also helps to prevent or repair neuronal damage when it's released. So it's a really, really good thing for the brain, and it not only might we try to target this artificially through gene therapy, but when we exercise, especially if we do cardiovascular exercise, that exercise causes our brain to produce this particular component, which is really just great for brain health and may reduce risk for Alzheimer's disease. And there's the idea of regenerative medicine, so using something like stem cells to actually create new functional neurons, so introducing new cellular components to the brain that might actually morph into neurons and take over older functions, which sounds very sci-fi, but it's pretty cool, some of the research that's being done. So you could probably imagine that there's a lot of different benefits to early detection. The earlier that we can determine that someone is going to develop Alzheimer's disease or is highly at risk for Alzheimer's is really, really going to help things out in trying to help that individual. So benefits of earlier detection: this enables earlier therapy and inclusion in clinical trials. It helps to prevent the prescription medications that might worsen cognitive function. For instance, anything that might cause drowsiness, sedatives, this type of thing, we wouldn't want individuals with dementia to be taking. It helps distinguish between different types of dementia so that we can be more focused in our therapy. Allows prompt management of symptoms. We can better monitor disease progression and treatment responses. And ultimately, it also allows more time for future planning by the individual and eventual caregivers. Alzheimer's disease right now is unfortunately a one-way road. And if we are able to let family members know what to expect in the future as a loved one advances through Alzheimer's disease, this has been shown to help out a lot in reducing stress and allowing for more appropriate reactions and caregivers, this sort of thing, and better care to that family. So as I said, early detection is really, really important, and a few things have happened lately that we're sort of excited about that might allow for some earlier detection. So one of them is blood-based biomarkers. Until recently, people have really had to have cerebral spinal fluid to be able to look at these types of markers and for them to be meaningful. But with some technological advancements, we're actually able to get meaningful information from blood with these same types of biomarkers. So in these blood-based biomarkers, just taking a sample of somebody's blood, we can now estimate levels of amyloid beta that have to do with these amyloid plaques. And we can measure things, estimates of tau. So there are different isoforms of tau, and we can measure these things. So there's phosphorylated tau 181, 117, 231. And these have been shown to be quite specific to Alzheimer's disease if they're elevated in blood. Also, tau 117 levels have been shown to correlate well to disease trajectory, meaning that higher levels in blood not only relate to the presence potentially of Alzheimer's disease, but also to how fast somebody is going to go downhill cognitively. So you can imagine that we have these amyloid and tau levels in the brains, and part of this sort of leaks out into our blood supply, and we're able to measure this in very, very small amounts. But again, now with technological advances, this has become meaningful. There are also non-specific markers of central damage. So there's a molecule called neurofilament light, and this relates to generalized neuronal damage. And there was another one called glial fibrillary acidic protein, or GFAP, and this relates to astrocyte activation, blood-brain barrier integrity. So these are proteins by which we might differentiate Alzheimer's from non-Alzheimer's if there's central damage and we know that there's, say, cognitive problems. So somebody who has multiple sclerosis, or maybe has had a stroke recently, or something like Parkinson's disease, very well might have elevations in NFL or GFAP, but we wouldn't expect in those individuals to see the same elevations in amyloid beta or in tau. So some recent findings from a study that I'm involved with in the Bronx, New York, in collaboration with the Einstein Medical College. Typically in Alzheimer's disease, we would see elevated blood levels of the various markers that I was mentioning. And so what we did in this study was we had, this was a little over 500 people, and we compared non-Hispanic Black individuals to non-Hispanic white individuals. And these individuals were either cognitively normal or they had mild cognitive impairment. They were all over the age of 70. And in white individuals, so just looking within white individuals, we found that individuals with mild cognitive impairment had higher amyloid beta and higher NFL than individuals that were cognitively normal or unimpaired, which is basically what we would expect. But looking within Black individuals, we didn't see these differences looking within race. And also, the overall levels of neurodegenerative biomarkers were generally lower in Black individuals than they were in whites. And we would have expected it in the opposite direction, because we know that incident levels of MCI and Alzheimer's disease are higher in Black individuals than they are in white individuals. So our conclusion here is that race-adjusted norms may need to be developed for proper interpretation of these markers. It seems that a lot of the past research has actually come out of places like Norway on these early research on these blood-based biomarkers using primarily white sample. And it seems that when we get into other races that maybe things are working a little bit differently. We have to take that into consideration. So we are trying to inform the literature in that fashion, that people may need to be a little bit more calibrated with how they use these data. Digital and cognitive biomarkers, everyone's walking around with smartwatches and smartphones these days, this type of thing, various different types of wearables. And by having these screens, this actually may allow us to detect cognitive problems in individuals more quickly. So if people were to perform cognitive tests every day, or maybe every couple of months, they perform a series of cognitive tests for a number of days, maybe then we'd be able to more quickly determine if somebody is having cognitive abilities, at least compared to what their cognitive ability used to be, and then to red flag that and try to intervene. We've done some testing like this, looking at people who have mild cognitive impairment versus cognitively normal, again, who are over 70 years of age. And if we look at overall cognitive performance, we didn't actually see any differences across a 2-week period where people were performing these tests about 4 times a day. But if we look at how variable that performance is, so if they performed cognitive tests for 2 weeks, 4 times a day, and we look at how well they do and how poorly they do on various different times of the day, we found a lot more variability in performance in people who had mild cognitive impairment. So we're pretty excited about this because we think that it may be these sort of nuances that we need to look at and not overall actual performance levels in individuals, but perhaps in this case, for instance, how variable they are may indicate some problems. To give you another example of this, these are mean responses for individuals in their 30s and their 40s and their 50s and in their 60s. So looking at middle-aged individuals now across the lifespan a little bit. This is across a 3-year period where people would carry these smartphones for 2 weeks a year for 3 years in a row. And the data here are showing spatial working memory errors. So the higher these values, the worse people are doing, if you look at these graphs. And we subdivided individuals here based on the amount of inflammation that we found in their bloods based on C-reactive protein levels. So we could put people into categories of low inflammation, medium inflammation, higher inflammation, and that's represented by the red and the green and the blue bars. So let me sort of lead you through this a little bit. So there are several different findings in this figure. And one of them is that as people get older, they tend to do worse on spatial working memory. So as I said, these are errors. And if we look at people in their 30s, their 40s, their 50s, their 60s, you can see these scores gradually getting higher across groups. So people are just doing worse with age. We also found that individuals tend to do better on this task across the 3 years. So here's the first year, the second year, the third year. And you can see that generally we have negative slopes, so that generally we're seeing an improvement across years. These are due to practice effects, that people just gradually get better on this task with time due to practice. And these practice effects, they're most notable in the older groups that have the most room for improvement. So we see practice effects in all of the various different groups, but we see the biggest, strongest practice effects in the older group. And if you look at just the red bars, you can really sort of see that pattern that these practice effects across 3 years are strongest in that group. And the last thing, and this is what we found to be particularly interesting, is that practice effects that I'm talking about are reduced with age in the group of the highest inflammation. So if we look here in people who are in their 60s, the red bar are the people with the lowest inflammation in their blood, and they show these strong practice effects. And we see these medium practice effects, and people have medium inflammation, and people that have high inflammation, they actually don't show very much improvement with practice across the 3 years. So we're actually pretty interested in this because, as I mentioned, it's not always the best parameter to show who's doing cognitively worse just based on cognitive performance. If we're seeing deficits in cognitive performance, somebody might be quite advanced along Alzheimer's and we're catching them quite late. But something that might be very, very sensitive to really early cognitive impairments might be something like not getting better with practice over time. So we are trying to further explore this just across the 2-week period that people carry these smartphones right now, and seeing if we can see differences in that sort of a shorter time period. But again, the idea of looking at cognition and trying to look at things like maybe variability of responses or not improving over time with practice the same way as being maybe more sensitive indicators of early cognitive decline rather than just overall cognitive ability and performance. So to get back to this idea of Alzheimer's quickly, this was discovered in 1906. And no progress has been made, unfortunately, in extending the lifespan of Alzheimer's individuals since then, which is what, it's almost 120 years, right? So people who are diagnosed with Alzheimer's disease live on average 8 years after diagnosis. I was doing research like this a little over 20 years ago, and back then it was 7 years after diagnosis. And the only thing that's changed in that time is we're diagnosing 1 year earlier. So we're not actually making huge leaps on this, unfortunately. So just quickly, what is the hope as we sort of come to the end of this? There are a number of different lifestyle factors that are modifiable that contribute to Alzheimer's disease. And we know that high blood pressure, diabetes, obesity, traumatic brain injury, think football players, soccer players, this type of thing. Those are all potential risk factors for Alzheimer's disease. But we also have things that can be protective. So we're gaining a better understanding that physical activity, social engagement, mentally stimulating pursuits, that these types of things can provide protective benefit against Alzheimer's risk. Exercise is really probably one of the strongest ones that I could pull out of that. As I mentioned, if you do cardiovascular exercise, we get this release of brain-derived neurotrophic factor in the brain, which is really, really good for brain health and preventing damage or helping to limit damage. And exercise is also anti-inflammatory. So there are various different molecules such as clusterin, irisin, that have known anti-inflammatory abilities that are produced when we exercise. We've also learned recently that people tend to lose certain aspects of smell with neurodegeneration, and this can occur up to 5 or 10 years even before the presence of symptoms. This doesn't happen from what we can tell in everybody who develops Alzheimer's disease, but in a large subset of people that seems to be there. So this might be something else that we're able to leverage for early detection. And only 10 years ago did we learn new aspects about sleep. I mentioned this clearance of amyloid from the brain being really, really important. And it turns out that this is actually one of the functions of sleep. And we only learned of this 10 years ago. So what happens when we are in deep wave sleep is that areas of our brain actually regress a little bit, pull back, and allow cerebral spinal fluid to sort of wash our brain. And we see a greater clearance of metabolites and toxins from our brain during that period of sleep than during other times of day. So you could think of sort of a dishwasher, for instance, and running your dishwasher at night and cleaning your dishes. It's sort of what our brain is doing while we're sleeping, while we're again in deep wave sleep. We did not appreciate this before, and this new research has now made us realize that people who don't sleep well, people who have sleep disturbances, this is actually a risk factor for Alzheimer's disease. And perhaps the largest part of hope comes from President Obama when he was in office, and he signed into law in 2011 the National Alzheimer's Project Act. And this basically charged the FDA and NIH with a national plan to address Alzheimer's, seeking to prevent and effectively treat Alzheimer's disease by 2025. We are now in 2023. And as I said, we don't have anything that lengthens lifespan in Alzheimer's yet. So we're getting a little desperate if we're going to make this 2025 timeline. So what happened in 2012 is $50 million extra was added to Alzheimer's research. And the following year, they upped it to 80 million, and the following year to 100 million, and then 313 million, blah, blah, blah. And this slide needs to be updated just as of today. There's a total of $3.5 billion in 2022 for Alzheimer's disease research alone. I can show you the figure of this. They just added $226 million more to Alzheimer's research about 2 days ago. So we're now up to about $3.8 billion just aimed at Alzheimer's research every year, which is really, really huge. So there is an awful lot of money being thrown at Alzheimer's research in this country. And I think that allows for a lot of potential for hope as well. So I'd like to just thank people for attending. I'm happy to take any questions, and I hope this gave some background on sort of the importance of early detection in Alzheimer's and where treatments and some research are currently heading.
Thank you so much, Dr. Engeland, for that really fascinating presentation. We really appreciate it. At this time, we are going to take just a few minutes so people have an opportunity to complete our post-event evaluation survey, which Jenny has just put the link for that into the chat. So you can also, if you have any questions that you want to ask Dr. Engeland, feel free to put those in the chat or in the Q&A, or you can also raise your hand. But we're just going to pause and take a couple minutes so that everybody can finish or complete that evaluation survey, and then we will come back for questions. Thank you. Okay, that's been a couple minutes and there's several questions that have come into the chat. So I just want to make sure we have plenty of time for that discussion. So I'll start off with our first question, which came from Cindy Keith. She said she's surprised to see that 40% of the time when someone is diagnosed with Alzheimer's disease is spent in the severe part of the stage, the final stage. So is this based on time of diagnosis? And do people who were diagnosed at an early stage and then died of pneumonia, just entering the late stage, excluded from those kind of study numbers where you would find that sort of finding?
Yeah, so it's based on which point, yes, from time of, I think it's from time of diagnosis, which probably isn't going to change that much from time of symptomatology. I would assume that if you went to different studies that number may vary a little bit. But the point of it is that people spend a reasonable amount of time in that later stage lingering. You know, it's the type of disease that does not, it's somewhat slow and it's insidious, unfortunately, and it really plays a lot of havoc on families because they end up dealing with this for years and years and years. And to me, it's just, one of the worst conditions a person can have, because if somebody has something like cancer, you have cancer and you may be in a lot of pain and that may affect your mood and this sort of thing, but you still are yourself. And with Alzheimer's disease, it really sort of takes away the individual because of the way that affects the brain. And people, again, the point of this being, it's slow.
And she had a second question as well about the blood-based biomarkers that she reviewed. And she just wondered if you have any information about the accuracy of those tests. So kind of like the validity of it. If you were to get a blood sample taken and you were to test positive for those different markers, does that mean you will get Alzheimer's disease, or is it just that you are at an elevated risk?
Yeah, so we're not quite there. This is not a clinical point yet. This is more at a research point. So what they've been able to show with the blood-based biomarkers is that they are able to differentiate in groups of individuals, people who have Alzheimer's from people who have mild cognitive impairment, from people who are cognitively normal based on these levels. There's a lot of variability of individuals' levels. And so it's not a diagnostic yet. And we don't have set points where we'd consider, oh, this level to be particularly poor. Part of the point that I was making is that in creating those set points, we're probably going to have to be cognizant of things like race, and that those set points are probably going to be different within different races. We're not going to be able to just clump everybody together. My guess is we may also have to look at change over time and determine that some of these levels, for instance, are perhaps increasing over time to their own baseline to be able to provide meaningful information to an individual. So we're not there yet. This is more at sort of the research level than the clinical diagnosis level.
Our next question comes from Lisa Ward about use of pharmacological interventions, I guess more for the behaviors of people who are living with Alzheimer's disease. And her question was, why do providers continue to use antipsychotics potentially as an intervention? Or if you're finding it maybe decreases.
What was the last part of that?
It just says, why do providers continue to use antipsychotics? And I guess I'm curious if you see the use of antipsychotics being decreased over time, or if you actually see the trend increasing.
It's decreased over, when you say over time, do you mean progression of the disease or over
history, I guess.
History. Antipsychotics are being used to treat current symptoms. And psychosis is not uncommon, especially in moderate stages of Alzheimer's disease. People don't tend to show it as much in early stages, and they don't show it in later stages. So there's some period in sort of the middle progression of the disease, once people have been diagnosed or shown symptoms, where they may undergo psychosis, and then that's administered for those particular symptoms. 30% of people that have Alzheimer's disease experience depression. So antidepressants may be given to those individuals. So there are some additional drugs that are administered that are treating, individual symptoms. I haven't seen anything suggesting that that's going away.
Thank you. Another question we got came from Catherine Beath in the Q&A, and she asks, what's your opinion about tests such as the Montreal test for diagnosing dementia?
We can diagnose dementia with various different cognitive tests. You really sort of need, a fairly stringent neuropsychological battery. If the question is Alzheimer's per se, though, then additional information is needed to determine it's Alzheimer's, not some other type of dementia. It's becoming more and more recognized these days that people may have more than one type of dementia at the same time as well. So I read recently that the most common type of dementia now, if you're over the age of 80, is actually mixed dementia, where it's more than one thing. So I just want to differentiate between diagnosing dementia and diagnosing Alzheimer's per se. So part of the issue is trying to differentiate between things, and it's somewhat difficult to diagnose Alzheimer's because we can do imaging where we can determine that somebody has high tau burden, high amyloid burden in the brain. We can do this through things like PET scans, but these are expensive procedures and are not covered by insurance.
Okay. We have a lot of comments as well in the chat, just thanking you for your presentation and that it was really informative. And we have another question from Sarah Songer, who asks, is the increase in the population of individuals diagnosed with Alzheimer's disease, I'm imagining, is that a result of greater diagnosis or an actual increase in the more prevalence of Alzheimer's disease in the population?
It's a nice question. It is largely due to aging population, but we are becoming a little bit more aware of Alzheimer's than we were arguably 10, 20 years ago clinically. Until people are sort of in the later stages of Alzheimer's disease, it wasn't always being diagnosed as much as it is now. So there may be some aspect of diagnosing it a little bit earlier. Not that we're catching it earlier per se, but that we're actually just putting it down as a diagnosis of people's charts. That hasn't always been done so well in the past, but largely it's due to an aging population.
I
You know,
think
and
that's, oh, sorry. Go
I
ahead.
just wanted to add one comment to that. You know, part of the problem with Alzheimer's is that the brain is very, very redundant in its functioning, which is a good thing. So by the time people show symptoms for underlying pathology, and this would apply to Alzheimer's disease, Parkinson's, a whole variety of different things, there's so much underlying damage to the structures at that point. Sometimes in certain structures, we see 40, 60, even 70% cell death with the time of the symptoms occur. That it makes it very, very difficult from that point forward to treat things. And this is one of the reasons that early detection and determination of early risk is so important to try to intervene earlier, you know.
I think that is actually it for what I see currently in chat or the Q&A, but again, feel free to put in any additional questions. I actually have one. I know you had mentioned in your talk that there had been about a 20-year gap between pharmacological sort of breakthroughs, or at least new drugs that were offered as potential treatments. Do you see, kind of putting on your forecasting hat, do you see that kind of pace picking up, or in the near future, or in the next, several decades, or do you kind of think we're sort of stuck at that length of time between potential treatments?
I see it picking up for a number of reasons. There were an awful lot of trials that were conducted between 2003 and 2021 that were focused on some of these sort of older ideas of trying to treat symptoms like cholinesterase inhibitors, that sort of thing. And there were over 100 trials that made it to, I think it was at least phase 3 testing in the trials that were discontinued in that time period. So there was a lot of research that was done. The biggest thing I'd say is that, scientific advancement is making maybe not exponential steps, but we're sort of increasing in the rate at which we're going. And there's so much money being thrown at Alzheimer's right now. If you look at that, this last figure here, that is a very, very steep curve. And so across 10 years, to be going from about $500 million of funding to $3.8 billion of funding, this is exceptional. This is not a funding curve for other areas of medical research, aside from maybe, I don't know what the numbers are for the opioid pandemic, but I know a lot of money is being thrown at that as well. So I think that people can see where this is, how much this is going to affect healthcare moving forward. And this large amount of money is going to, I think, be a game changer for what's being done research-wise. And there also seems to be a different attitude towards pushing drugs forth for Alzheimer's right now, which I said has been somewhat controversial among certain individuals, but I think that's also a factor. So I would expect that we're going to continue to, 2023, I would say that it would surprise me if we don't see several other treatments this decade passed by the FDA.
I think we had a hand raised, so I think maybe we have time for one last question.
Virginia?
Yes, Virginia, if you want to unmute yourself and ask your question. I can see you're unmuted, but we can't hear you.
Can you hear me now?
Yes.
Okay, great. How does early detection of Alzheimer's disease usually affect insurance coverage by Medicare? If you have that diagnosis, sometimes it's not a great diagnosis in the long run. And I don't know. Do you have any comments?
How earlier diagnosis affects medical care? That's a very, very difficult question. People can go in for genetic testing, right, to determine if they're going to develop certain conditions in the future. And early onset Alzheimer's, which doesn't affect as nearly as many people, that is something that people can be genetically tested for to see if they have certain gene mutations. And it is an issue going in and having genetic testing done like that for what it potentially could do to insurance rates, insurance coverage, and even job prospects and things like this if it's made public, right? So this is all, it's a very difficult question to answer, but there's a lot of different ins and outs to that.
All right, well, I think we actually are at our time for the hour. I know there's a few last questions in the chat and the Q&A that we weren't able to get to, but I can send those on to you, Dr. Engeland. Maybe you can follow up after our session here today. Thank you so much for being here and for presenting with the CGNE. We really appreciate it. And thank you to our audience for joining us today. Just a reminder, if you weren't able to complete the evaluation survey in the time we gave you, please go ahead and complete that now. It will also be sent out in an email within 24 hours. And just remember, if you are an RN and you are looking for those contact hours, it does need to be completed within a week. And then the certificates will be mailed to you in 1 month. So thank you so much for joining us.
I would like to thank everyone for their time. And if you do have follow-up questions and you'd like to email me directly, that's fine as well.
Thank you so much.